Welcome, everybody. I just want to introduce my amazing colleague, Dr. Leanne Byker. He is a family doctor, internal medicine doctor, intensive care doctor, and ultrasound trained physician. We welcome him today. He's presenting from the U of A hospital, and I just want to give him a round of applause for him coming here to do this. And we really appreciate him being here. So thanks, Leon.
Thank you so much. Sure. Thanks for that kind introduction, Brian. So first of all, I have no declarations in terms of big pharma or big sono or anything like that. We do this purely because we love it. I am not a cardiologist. I do not pretend to be a cardiologist, and I guarantee you that a echo-trained cardiologist will know 99% more about echocardiography than me. Having said that, we do practice and are trained in critical care echocardiography that really overlaps a lot, and we borrow a lot of their ways to try and answer very specific questions. You should also know that this talk is not going to be science heavy. I thought instead of giving you a bunch of papers to read that you're not going to read anyway at whichever point, I am going to try, and my aim is to give you some practical stuff regarding the pericardium and how to recognize a pericardial effusion, and more specifically, when it is too much. I'm told that a case narrative is always a good thing to peg whatever we're going to learn today. So let's start with a case. This is, of course, a real case that I saw about a year ago at the Grey Nuns Hospital. It's the case of a 60-some-year-old gentleman who presented to the hospital with acute kidney injury and required urgent hemodialysis. Now, I can't remember the exact ABCDE, or rather I should say AEIOU reason for his dialysis, but suffice it to say he required dialysis. The concern, however, was that this gentleman had a pericardial effusion. And this was picked up by a very astute emergency physician who did a bedside focus the night before when this patient was admitted, and found a not small, not insignificant pericardial effusion. Cardiology was consulted, and at that time, the patient's hemodynamics were fairly acceptable, and they felt that it's probably a uremic pericarditis, and felt that that's just another indication then to get this patient onto dialysis. At our center, we try and work closely with other subspecialists, and we often would accept patients like this into the intensive care unit to start their urgent dialysis run, just because you never know what's going to happen. So one of the first things we did, of course, was we put a probe on. And I think maybe just some audience participation would be great, and maybe we'll start by picking on the people in the lecture hall right here. What do you guys see? So this is an apical 4-chamber view of the heart. So any comments? Just throw it out there. There's no wrong answer. Okay, so we see a hyperdynamic heart. True. Anything else that jumps out? Sure. So yeah, there is a pericardial effusion, and I'll just get the laser pointer. You can see it sort of over there. Now, granted, you can easily miss that with this short clip and view, but yeah, it's certainly there, and certainly from this view, it does not look insignificant. So I tried. Ironically, this patient actually had difficult views. But we tried to find the biggest part of this effusion, and I think you'll agree with me that here it is much bigger and not all that insignificant in regards to size, right? In fact, we measured it, and it was about 2.8 centimeters in size. The next thing we did was we wanted to know if this is going to be hemodynamically significant, and I think you'll agree as well. If we're going to remove preload from this patient by putting them onto a circuit, and then the circuit vasodilating them, we can run into huge problems if there is significant intrapericardial pressure. So we did, essentially, we looked for if there's a respirophasic variation across the mitral valve inflow. Now, if you don't know what that means, that's okay. This is just one of the ways, and we'll get to a little bit of the detail in a bit, but this is one of the ways to tell if there is significant cardiorespiratory variation, high intrapericardial pressure being one of the reasons for it. Now, you can see here, after calculating it, there was about a 38% variation in the cardiorespiratory phases. Now, many of the echo machines have ECGs. At this time, we didn't have an ECG. And you can also, on some of the leads, measure or show graphically the respiration phase, which we also didn't have. Suffice it to say, there's significant variation, and really discovering whether it's in the inspiratory phase or expiratory phase at this point is just going to get you lost in the weeds and not really be very helpful. We did think that this was very significant, however. And so before we put this patient on dialysis, we spoke to our friendly neighborhood cardiologist again, and we got their attention, and they came along and helped us out with the pericardiocentesis, which was a bit of a tricky procedure to do as an aside. So we successfully drained it, and I can't remember exactly the volume that came out. But interestingly, this patient's hemodynamics, which wasn't on face value too bad, he was at about 100, mid-100 systolic, actually improved remarkably. He became hypertensive, in fact. So relatively, this patient was, in fact, hypotensive. I had a fellow on at that time who very, very astutely went back. And it was interesting because this patient presented approximately 3 months prior on several occasions to his local emergency department with chest discomfort. One of his presentations, he was actually in atrial fibrillation, and he was treated at that time with a DOAC as well as a beta blocker to slow him down. This is one of his initial ECGs. And if you look closely, you'll see that there is actually evidence of a pericarditis here. There is slight sort of saddling of his ST segments, which is fairly widespread. And then fairly prominent, he's got these PR depressions that led us down the belief that he actually, his chest discomfort, etc., prior was probably pericarditis. And he may have had perimyocarditis or something like that, which caused his arrhythmia, and he ended up on a DOAC, and then actually had a hemorrhagic transformation of his pericarditis and a subsequent effusion. So very interesting. We had this patient go on to dialysis. He completed probably about 3 runs of dialysis and then didn't require it at all anymore. So this was certainly a hemodynamically significant lesion, if you will. And be it because there was venous congestion causing, much excitement in the VEXAS world, and cardiorenal syndrome, or if he was just actually hypotensive, relatively speaking, causing an ATN. Either way, he had a good outcome, and he ended up on colchicine, et cetera, treating his pericarditis. So this was really a cool case. So when we think about pericarditis, or I should say pericardial effusions and tamponade, we are classically taught about Beck's triad, and we are classically taught to couple that to pulsus paradoxus. And Beck's triad, of course, being muffled heart sounds and elevated JVP, and hypotension. And then your classic pulsus paradoxus being a variation of more than 10 or 15 millimeters of mercury on inspiration. Now, this is important because the physiology is important to follow through. And what I'm going to attempt to do is show you that there are similarities to diagnosing it clinically and diagnosing it on echocardiography. And again, I'm going to try and keep it simple, like I said, and really give you some take-home stuff and stuff that you can take with you, and especially tools on how to get the attention of people who can help you when you meet a patient like this. Right, so to do that, we have to get into a little bit of physiology. Now, I told you I'm old, so you'll notice that there's a green sort of background to this. I don't know if you recognize it as a green board that you can write with chalk on, and some of you may remember chalk that you used to write on your parents' driveway.
I was going to say
with.
whiteboard. I thought it was a whiteboard.
Yeah, so this is not a whiteboard. This is a
board.
green board. Green or a blackboard is what I grew up with. And you'll also notice that I use some cursive.
You stole my heart. I love cursive.
Now, there may be some cursive dyslexia in the audience, so I will try and you'll see in the future or in the subsequent slides why that's necessary. But I'll translate. Okay, so I think the first thing that we need to consider in regards to physiology is the concept of transmural pressure. And essentially, transmural pressure is represented in this formula, where you have two pressures on either side of a wall, for instance. That's where the mural part comes in, I guess. And the pressure that is felt through that is then the difference between pressure 1 and pressure 2. And you may ask, so what? Why is this important? Well, if you consider something like the heart, which is really very similar to the Monroe-Kelly principle in the brain, the heart muscle, the blood, and the pericardial space all compete for the same intrapericardial space, if that makes sense. So if there's volume change or pressure change, something has to give, right? So under normal circumstances, ventricular inflow and volume is determined by the transmural pressure, right? So if you consider an abnormal situation like this, where your transmural pressure changes because there is a change in your intrapericardial pressure, your transmural pressure decreases, and that as a consequence causes decreased filling into that chamber, decreased change in size, if you will. So your chamber is smaller and it fills less. Okay, that's the first very important thing to consider when it comes to physiology. The second thing is this concept of cardiorespiratory interaction or variation. And really, to conceptualize this, it's kind of useful to think of it in two ways. The one is that the right ventricle and the left ventricle is in series, and you'll recall from physics and doing some electronic stuff growing up in medical school and so on, that this, of course, the one chamber follows the other one. Then there is the theory or the concept of the right ventricle and left ventricle actually being in parallel. In other words, right next to each other, where they can interact and have interactions regarding filling, regarding pressure, etc. So if we look at these a little bit closer, if you consider the right ventricle and left ventricle being in series, this is essentially what happens. Firstly, what is not on here is the right ventricle, right? So we know that with every inspiration, I guess, your venous pressures drop. So your venous pressure on the right side drops, but your pulmonary venous pressure also drops. So what it means for the right side is that your venous return actually increases, and it increases your right ventricular filling. The opposite happens on the left side. So if you look at this graph here, as you inspire, your intrathoracic pressure drops, but so does your intrapericardial pressure, and so does your pulmonary venous pressure. And because your pulmonary venous pressure drops with everything else, your filling is actually a little bit less on the left side. I think that follows, right? That's an important concept to realize, because you have to understand this to understand the concept or the structure of a parallel ventricle system. So if we consider that next, with the right ventricle and left ventricle being parallel, and this is where we are going to get into the weeds of interventricular dependence. We've already established that on the right side, during inspiration, your right ventricle fills a bit more. Your left ventricle fills less. Because it fills less, if there is any changes on the right-sided pressure, it will cause a bowing of your interventricular septum into the chamber that is filled less, which is in this case, during inspiration, the left ventricle. The opposite happens when you breathe out. So during expiration, your left ventricle actually catches up. It had a little bit more of a preload coming from the right side, and your pulmonary venous pressure actually goes up again. So your left ventricle fills more, this time giving you bowing of the septum into the right ventricle. This is normal physiology, okay? But so what happens then in an abnormal situation? In a situation like tamponade, where there is raised intrapericardial pressure, well, fisherman's stories, of course. Everything is exaggerated, okay? Let's start again with the transmural pressure. So your pericardial pressure goes up, your transmural pressure as a consequence goes down, and your thinnest walls will start collapsing first, and this is called diastolic collapse, okay? We'll get into that in a little bit more detail soon. When we speak about the hemodynamics in tamponade, with the ventricles being in series, you'll notice here first on this side, this is the normal, okay? This is what happens normally. This is what happens during a tamponade. So your intrapericardial pressure is so high that that left ventricle really loses its compliance. So it's going to be filling less under normal circumstances. And now because of this high pressure in the pericardium, it's going to fill even less. Okay, so you do get a drop in cardiac output as a consequence. All right. So far, so good, I hope. Respiraphasic variation also gets exaggerated, and you can see it in this nice little graph. So during inspiration, as we already established, right ventricle fills a little bit more, and that bow, or that causes bowing of the ventricle. If you have a raised intrapericardial pressure, the only place where that volume can go is into the space of the left ventricle. So that gets exaggerated. The same happening during expiration because of the left ventricle filling more, as we've established a little bit earlier. So you get exaggerated inspiration, expiration changes in your cardiac output. And this is what we find with a sphygmomanometer when we look for pulsus paradoxus. Incidentally, the paradox of pulsus paradoxus is that a live person has a pulse that disappears. That's where the paradox lies. Okay, so enough with physiology and pathophysiology. Let's get to the question of, does size matter? Of course, it doesn't. What matters is how quickly this pericardium fills. And that's clearly demonstrated in this volume, and it should really be a volume time curve. So if your volume expands over a long period of time, your pericardium has time to adapt. And this is typically what happens in something like a TB pericarditis, for instance, where you can have massive effusions that almost never becomes hemodynamically significant. Yet the patient has a big bag in their heart with a small heart floating around in it. In their chest. Whilst if you have a rapid filling of the pericardial space, that quickly gets met with a very rigid pericardium, and your pressure just rises very, very rapidly, right? I think that makes sense. So size doesn't matter, but the period in which that volume increases certainly has a big, big role to play on intrapericardial pressure. So if we try and bring it all together and look at the hemodynamic consequences of everything, I think the first thing to look at is the green graph. So you have intrapericardial pressure that goes up. It reaches an inflection point and just starts going up very rapidly. Your right ventricular filling pressure also goes up. And remember, this is because you lose the ability to have your ventricle, it loses its compliance, right? So that end diastolic pressure is going to go up because our transmural pressure changed, right? That makes sense. And the same thing's going to happen on your left ventricular side. And you'll notice, and this is the classic teaching too, when your intrapericardial pressure reaches the same pressure as your end diastolic pressure on the left and on the right, that's when you have a very sudden demise in your cardiac output. And that is where cardiac tamponade happens. And that is bad. goes without saying, I guess. So this is what happens to your heart, and I'm sure that you've heard of the death spiral of the right ventricle in things like acute pulmonary hypertension, in a PE, for instance. So let's go through this. So accumulation of fluid in the pericardium, interpericardial pressure goes up, your cardiac chamber gets compressed, diastolic pressure goes up, and filling goes down, right? That reduces your cardiac output, and to a point where your coronary perfusion and your systemic perfusion is so low that you die. So this is the death spiral of cardiac tamponade. Okay. Now, what can we do about it? What can we look for on basic echo to try and recognize this, and more importantly, to try and recognize hemodynamically significant lesions? So what are the nuts and bolts of it? Right, well, so let's break it down in 4 steps. So the first thing is seeing and sizing up the effusion. So this is a tricky one. And I wonder again if we can get some participation from the audience for this one. So this is a subxiphoid view of a sick person's heart. And I'm wondering if we have any volunteers that'll be willing to tell us what they see. So we're giving you the view.
So you have a subxiphoid view
Uh-huh.
of your right ventricle, the top of the screen. the
All right.
left ventricle, and the right side of the screen.
Okay, left ventricle, check.
Septum in between.
Right.
So right now I'm not seeing signs of septal bowing during diastole.
Okay.
Which would, but I need to get pericardial effusion, but I wouldn't say just from this view.
Okay.
Signs of tamponade.
Okay, so we've established this is the right ventricle, this is the left ventricle, that's the septum. We do not appreciate any significant sort of bowing on this view anyway, and there is a pericardial effusion. My question is, where is this pericardial effusion? And how big would you say it is just on face value?
Small.
Okay. Is this the pericardial effusion over here?
I would say no.
You would be correct. He said no. So this is actually the effusion. It's actually very tiny. So there you can see effusion, and there you can see effusion. So this is one of the pitfalls, and it was a bit unfair of me to start with this slide, but this is actually a ascites. So it's just one of the pitfalls to look out for, right? That's why we have more than one view, okay? What about this one? So I think we can clearly see that there is significant amounts of fluid going on here. Right now, try and not look at too much that's going on here. But of course, saying that, it's very important to know that too, because you can see a hyperdynamic heart, you see a small sort of LV, maybe looks underfilled, and you see a lot of action going on there in the right ventricle. But this is a more significant, perhaps bigger as the previous one. And I think that's what I tried to illustrate with this one. So really sizing it up, less than 10 millimeters is trivial. Small would be larger than that, so 10 to, moderate is 10 to 20, and then a large would be more than 20 millimeters. The best place to measure this is usually in the subxiphoid view. Having said that, it really doesn't matter where you measure it. You should probably measure in the largest area, but be careful not to fall trap to overestimating the size because you are off axis, for instance. So that's why standardization is not a bad thing. So it collects mostly, the best place to see it would be on the subxiphoid. So that's probably where the money is.
If I can ask the gang here.
Sorry, yeah, go ahead.
But how come it says measured end diastole?
Right, so the question was, why do we have to measure it in end diastole?
Not end systole.
Just imagine when the heart's contracting, it's going to make the effusion look larger.
Yeah.
Right, yeah.
It's diastolic, so it's expanded.
So we've just established that at end diastole, the heart is maximally filled. And so you're not going to overestimate the size of your pericardial effusion at that time. Whereas in systole, your chamber is arguably collapsed, and your effusion can look better. Thanks, Brian, for bringing that up. Okay, let's go through some pitfalls here. One of the first ones is, what is this red arrow sort of pointing at? And this is a terrible one. I do have a better one coming up. So this is a parasternal long axis view of the heart, and the aorta lies there. Pleural effusion. Why do you say that? So the answer is pleural effusion. Yeah, exactly. So it extends beyond the aorta. So we'll explore that in a future slide here. In fact, this one. So here you can clearly see that that's where the aorta is, right? The thoracic aorta. And you can see blackness there, which represents fluid. So this is a pericardial effusion, and it goes in between the aorta and the rest of the heart there, right? If it extends beyond the aorta, if it doesn't, I'm not going to say the word, if it doesn't go in there, then it's not a pericardial effusion. It's important to know because you can sometimes have both of these. So that's pitfall number one to look out for. And in fact, here is that very case where you have the aorta over here. You have a pericardial effusion, which is not big, but you also have a pleural effusion, right? All right. Okay. Another pitfall is epicardial adipose tissue. So if you see some blackness in the pericardial space that is limited to one area that has some opacity to it at times and moves with the myocardium, it is probably epicardial adipose tissue. So just be on the lookout for that. What about this one? And I think some audience participation would be important for this one again. So what do you guys think? Okay. And didn't you have a case like this, Brian? So yeah, so the answer was this is a complex effusion or a complex collection inside the pericardial space. Now, this one is a dead giveaway, but sometimes that whole area is sort of echogenic and you can't really see. And this happens typically in dissection, for instance, if you have a pericardial hematoma or a hemopericardium, or if there is a chamber rupture or something like that. And it's actually easy to miss then, but you can hardly see the RV opening, right? So this is a hemodynamically very significant lesion, very likely, okay? So it's just important to know that sometimes you have to look a little bit closer. And again, that's why multiple views are very, very important.
It's a very pretty view.
All right. Step 2, chamber collapse. Now, I don't want us to get lost in the weeds here by speaking about early diastolic, late diastolic, pan. It starts in early diastole, right? And the longer into diastole chamber collapse lasts, the worse it is, the higher your pericardial pressure is going to be, right? An ECG lead at this time is incredibly helpful because it's going to help you establish in which phase of the heart you are, right? But I promised you sort of take-home points. And I think if you see a significant pericardial effusion or a pericardial effusion with associated chamber collapse, that should be a red flag. You should get somebody who can come and look at this closer, right? So the way that I conceptualize it as well is that it's always in diastole, right? It's either ventricular diastole or it is atrial diastole, which are different phases of the heart. But that's just a way to kind of look at it. One of the ways you can also look at this is by dropping M mode down, which I don't have a picture of, and that'll slow things down and you'll get a longitudinal sort of picture to see if this chamber collapse. All right, so looking at this one, so this is a kind of an inverted or emergency view, I guess, of the pericardium from the subxiphoid area. So it's just inverted. Do you think there is chamber collapse? Yes or no? I'd be worried. What about this one? I think so. I think you can see early diastolic collapse there, right? What about this one? So there's a potential pitfall in this one too, but I think there's a biggish effusion, and it certainly seems like there is chamber collapse. It's not all that clear. You know, there is echogenic material sort of sitting on the heart that may be obscuring our view. I'm not quite sure if it's epicardial arteries that's calcified or something. I don't know what it is. Either way, be careful that you're not off axis, because you can actually cut off the RV altogether, right? So make sure that you turn your probe a little bit and make sure that you do find the biggest area. I do, however, want you to notice how empty the left ventricle is here. And it follows, if your RV is not filling properly, your LV is never going to fill properly either. So that's the second red flag here. So you have chamber collapse, you have an effusion, and you have this underfilled LV. Okay, so your spidey senses should be buzzing, right? So random, I know, but this is often compared to a little man jumping on the chamber. And if you look at somebody jumping on the chamber and there's an effusion and there's hypotension, be worried, okay? Call someone, call a friend, okay? Next, you have to wonder what the IBC says. Now, I was often taught in medical school that you have to try and judge clinical signs and signs by the company it keeps. So if you have a pericardial effusion and you want to know if it's hemodynamically significant, one of the surrogates for right ventricular filling is looking at the IVC. And this is the equivalent of a raised JVP of the Beck's triad. Okay, so let's look at that. So you can see some respirophasic variation. If you look at the side, there we see 10 to 5 centimeters represented for us. So I think we can agree that that IBC is pretty juicy, right? So if this is seen in the context of a pericardial effusion, that should be another red flag, okay? So this IBC is saying, I'm not happy, I can't get into the right ventricle, okay? So here we have a side by side. We have a pericardial effusion with what appears to be some collapse of the walls. But if you look at the IVC, it seems pretty decent, doesn't it? It seems like it's small. It doesn't seem to be, it seems like there's some respirophasic variation in it. Just be very careful, especially if you're going to be looking in the longitudinal aspect or longitudinal plane of the IVC. You may be completely off axis, okay? Make sure that you're seeing it in its biggest. So you've got to move your probe a little bit to make sure that you're not seeing it. In fact, a better way to do it is to look both in the longitudinal and short axis of the IVC, okay? So you can appreciate here on the left, screen left, you can see an IVC that just appears like it's just collapsing all the time, right? It's hardly impressive. But if you look over here, it's actually not collapsing completely. And this is just to illustrate that you do need to be careful and make sure that what you're seeing is the truth, right? Right, so what does the IVC say? Is it juicy? Is it plump? Is there a diffusion? You're in trouble, right? Here's a nice example again. In fact, this one, it probably doesn't show well, but there's some echogenic contrast or IVC smoke or whatever you want to call it. That just means that there is real sluggish flow in the IVC. For the Vexus files, I guess, you can also see a very juicy hepatic vein there, which is if you look at Doppler flows of that, you'll probably see some reversal and stuff. We're not going to get lost in the weeds there, I promised you. All right. Step 4. Look at them transvalvular, or rather tricuspid valve and mitral valve inflows for echocardiographical pulsus paradoxus. Now, if the following doesn't make any sense to you, this technique is not for you. This takes practice. This takes training. So if you're not sure what pulse wave Doppler is, if you're not sure what E to A waves are and what it represents, if you're not sure what a constrictive E to A wave ratio looks like, then this is probably not for you, and don't worry about it. This is a neat way to get people's attention, okay? But what we're essentially looking at is the rise and fall of cardiac output, or at least of inflow into the left and right ventricles. You will recall the physiology that we discussed, and that there is going to be variation. And there are cutoffs to try and determine if it's significant variation or just physiological variation, okay? So for those who are interested, how do you do this? Well, you do a apical 4-chamber view. And this is more or less what you see on screen. So you would use pulsed wave Doppler at the inflow of the left ventricle as well as the right ventricle. And we're going to focus a little bit more on the left ventricle, but what you see there represented is your normal E and A inflow waves. So you get passive filling, which is the majority of diastolic filling, the E, and then you get the A wave, which actually represents, if the patient is in sinus rhythm, the contraction of the atria, okay? These two waves actually invert, so your E wave goes down as your end diastolic pressure increases. It makes sense. Remember that transmural pressure thing we spoke about? If it's high, if there is loss of compliance of the ventricle, the blood's gonna not the blood's not gonna flow in as rapidly as it would under normal physiological circumstances. So that will be inverted. Okay. So the cutoffs, as I mentioned, for the mitral valve, it is 30%. For the tricuspid valve, it is 60%. And this is the latest ACE guidelines. And you'll recall our one right at the beginning, there was a 38% variation on the left. So how do you calculate it? Well, it's the expiratory minus the inspiratory over expiratory, okay? That's how you get there. Okay, again, don't get lost in the weeds. This is not super important to be able to do, because somebody with the skill, after you've gotten their attention, will come and do this, okay? There are some pitfalls. Extreme hypotension will give you worse variation, a focal pericardial effusion, which is everybody's nightmare and keeps you up at night because you always wonder, did I miss it? Right ventricular pathology can give it to you, right ventricular failure. High left ventricular filling pressures for diastolic dysfunction, for instance, can give it to you. If there is atrial regurgitation, aortic regurg, ASDs, and then mechanical ventilation gives you difficulty in it too. So let's take it all together. So the take-home points. How are you going to grab the attention of your needle-wielding cardiologist? And I think this is really the important part, okay? So if you have a patient that is hypotense, that has a pericardial effusion, that has what you think is chamber collapse and a plump IVC, these are the steps. Put them on IV fluid, give them a fluid bolus. Pick up the phone and speak to your neighborhood cardiologist. Tell them you have a hypotensive patient with a pericardial effusion. You can see chamber collapse. You see a plethoric IVC, and you are worried about raised pericardial pressure. Notice I didn't say you're worried about tamponade, because the moment you say tamponade, they're going to ask you, well, do they have pulsus paradoxus? And good luck to you to find a sphygmomanometer, because I don't know when last I saw one. It's noisy. It's not something that we're particularly good at necessarily. So that's the way that I would phrase it, and that is actually the way that I have phrased it. And I am very lucky to work in a community ICU where we work very closely and collaboratively with our cardiology colleagues, and it's normally never a problem. It can be a problem at 3 a.m., but they will come and help you. Okay, that is if you have that luxury of having someone. If you somewhere out in the community where you don't have this is a procedure you may have to do yourself. And this it goes way beyond this talk. So we're not going to delve into that at all. All right, so hypotensive patient, pericardial effusion, chamber collapse, plethoric IVC should make you worried about it. Raise pericardial pressure, give fluid, and phone the cardiologist, okay? Any questions? I think, yeah, you guys have been under fire in the room here, so why don't we open the floor to the room first, and then we'll go to some chats if there's any questions there.
Who here has had a case of tamponade like in the last 6 months? Anybody? Last 12 months? Last 2 years? Yeah, I guess. Yep. How did they get picked up?
I was on CT,
Okay.
we were the ones who but it was through focus.
Focus. Oh, interesting. Yeah, that's probably, that's happening increasingly more and more, right? I mean, historically, people pick it up by looking at like an ECG with, with like the very small complexes, like, the kind of, on a clinical exam perspective, like pulses can be done by, frankly, very few physicians can do it properly. And now, because of finding sigma-manometers, it's even more challenging. So, like historically, before ultrasound was available everywhere, like even when I did my internal medicine residency, like it wasn't very common for you to find an ultrasound machine just to look at someone's heart. That's like now you call someone to do that. So you just be like, oh, they're hypertensive. I guess I'll just query effusion and just call somebody to come rule it out. So ultrasound made it much more simpler to say like whether there is or isn't, because obviously if there's no effusion, well, can a tamponade if there's no effusion? Frankly, it's not that challenging to rule it out. But the ruling in part actually is very, very challenging from like an echo standpoint. But the stuff on an echo is actually very much like the same as stuff on a clinical exam. So all the variation in mitral and transient inflows and even outflow tract velocities are really just the kind of mirror image internally of what you see externally with pulsus paradoxes. So, I can tell you when I've taken a lot of phone calls about tamponade, and I've asked them to do pulsus paradoxes, and it's very few physicians I've talked to who can actually do it. Interestingly, so a lot of physicians forget. So Jeremy Webb here says big point mentioned may not see classic mitral inflow variation changes in patient pulse pressure and invasive ventilation. Yeah, and I think there are a lot of limitations with patients who are on invasive ventilation in terms of classic findings, and even like again, the findings can be fairly specific, but in terms of the sensitivity, it's definitely more limited in terms of sensitivity.
Yeah, the physiology reverses, of course, as well. But yeah, it's one of the pitfalls, as we mentioned. And that's why I didn't want to, emphasize it too much, because I think if you see a plump IVC, you see some chamber collapse and a biggish effusion, that's enough for them to come and have a
Totally.
Especially if the patient is hypotensive. I guess that's a given. Now, having said that, of course, somebody on positive pressure may have right ventricular dysfunction anyway with a plump IVC, et cetera, but that's why you get somebody to come and have a look, right? All right.
Excellent. Well, thanks a lot, Leon. I really appreciate it. Thanks everybody for attending.
Yeah, you're welcome.
And great discussion.